Today we will be discussing protein synthesis inhibitors. So there are a number of antimicrobial antibiotics that specifically target bacterial ribosomes by inhibiting bacterial protein synthesis. Prokaryotic ribosomes have a 30S and a 50S ribosomal subunit, whereas eukaryotic ribosomes are composed of 40S and 60S ribosomal subunits. The differences between these ribosomes are clinically relevant because the antibiotic drugs we will be discussing today are designed to target the prokaryotic ribosomes over the eukaryotic ones, based on their structure. Mammalian cells are eukaryotic and are generally not harmed by these antibiotics that target the prokaryotic ribosomes found generally in bacteria. However, negative effects may occur if mitochondrial ribosomes are interacted with due to their close resemblance to the bacterial ribosomes. First, we will be looking into tetracyclines, which are a class of broad-spectrum antimicrobial antibiotics that act as bacterial protein synthesis inhibitors. They are a group of antibiotics that include dinucleocycline, doxycycline, minocycline, and tetracycline. These tetracyclines have very similar structures, consisting out of 4 fused rings with a system of conjugated double bonds. The name tetracycline originated based on their structure. Tetra means 4 and cycline basically meaning ring. The substitutions on these rings alter the individual pharmacokinetics and spectrum of their antimicrobial activity. Tetracyclines can either enter susceptible organisms via passive diffusion or via an energy-dependent transport protein mechanism that's unique to the bacterial inner cytoplasmic membrane. Tetracyclines will then concentrate intercellularly in these susceptible organisms. Once inside the organism, the drug will bind reversibly to the 30S subunit of the bacterial ribosome, preventing tRNA to bind to the mRNA ribosome complex, thus inhibiting bacterial protein synthesis. Administration routes of tetracyclines are per oral and topical. Doxycycline and minocycline can also be given via an IV. Administration with dairy products or substances that contain divalent and trivalent cations, like magnesium and aluminium antacids or iron supplements, may decrease absorption. Tetracyclines concentrate well in the liver, kidney, bile, skin, gingival fluid, and almost all other body fluids. Moreover, they bind to tissues undergoing calcification or even to tumors that have a high calcium content. Minocycline achieves high levels in saliva and tears, rendering it useful in eradicating the meningococcal carrier state. All tetracyclines cross the placental barrier and concentrate in fetal bones and in dentition, and this is why they are contraindicated for pregnant or breastfeeding women or in children less than 8 years. Tetracycline and doxycycline aren't hepatically metabolized. Tetracycline is primarily eliminated unchanged in the urine, whereas doxycycline is primarily eliminated in the feces. Minocycline, on the other hand, undergoes hepatic metabolism and is eliminated to a lesser extent via the kidney. Because tetracyclines are bacteriostatic antibiotics, they are effective against a wide variety of organisms, including gram-positive and gram-negative bacteria, protozoa, spirochetes, mycobacteria, and other species. They are commonly used in the treatment of cholera, Lyme disease, Mycoplasma pneumonia, or as we know it, walking pneumonia, chlamydial infections, and Rocky Mountain spotted fever. Resistance to one tetracycline doesn't mean that there will be a universal resistance. Resistance typically occurs due to either an influx pump that expels the drug out of the cell, preventing intracellular accumulation of the drug, or bacterial enzymatic inactivation of the drug, or production of bacterial proteins that prevent tetracyclines from binding to the ribosome. Tetracyclines may cause phototoxicity, where patients are more prone to severe sunburn. Hepatotoxicity may occur with high doses, particularly in pregnant women and in patients who have pre-existing hepatic dysfunction or renal impairment. Gastric discomfort or distress may occur and often results from irritation of the gastric mucosa by the tetracyclines. Discoloration and hypoplasia of teeth may occur, as well as temporary stunting of growth. This occurs primarily in growing children and is caused by tetracycline accumulation in calcified tissues. Vestibular dysfunction resulting in vestibular symptoms like dizziness, vertigo, and tinnitus particularly occur with minocycline, which concentrates in the endolymph of the ear and affects its function. Pseudotumor cerebri may occur, which is characterized as benign intracranial hypertension.
Glycylcyclines are a derivative of minocyclic drugs and are used as a treatment for dermatological and soft tissue infections. Glycylcyclines perform their purpose by inhibiting the synthesis of proteins by specifically targeting and reversibly binding to the 30S ribosomal subunit. Glycylcyclines were originally produced as a means of eliminating organisms that have developed resistance to protein synthesis inhibitors through the utilization of efflux pumps and ribosomal protectors. Although when such factors are in high excess, resistance to glycylcyclines is also observed. Glycylcyclines penetrate tissues rather easily, therefore they have a high volume of distribution. A high volume of distribution results in a low plasma concentration. The primary route of elimination for glycylcyclines is through fecal discharge, and dose reduction is only considered for patients with severe liver impairment. Side effects include nausea and vomiting, acute pancreatitis in severe cases, an increase in liver enzyme and serum creatine production, photosensitivity, and glycylcyclines can be harmful to an unborn fetus due to its ability to cross the placental barrier. Aminoglycosides are used to eliminate gram-negative bacilli in cases of severe infection. The structure of these protein synthesis inhibitors, two amino sugars connected to a central hexose nucleus by a glycosidic chain, makes the drug significantly toxic and limits its clinical use. Gram-negative bacilli are affected by aminoglycosides when the drug is absorbed through pore-in channels. The drug targets 30S ribosomal subunits, disrupting the formulation of functional ribosomes or causes errors in translation of mRNA to proteins. The concentration-dependent bactericidal characteristics of aminoglycosides refers to the direct relationship between the effect of the drug and the concentration of the drug present. The greater the concentration, the greater the effect. Resistance to aminoglycosides occurs when the target bacilli adapt their efflux pumps to increase the disposal of the drug from their cytoplasm, or by reducing drug absorption through pore-in regulation. Resistance is also acquired through deactivation of plasmid-associated enzyme synthesis, which is the target process of aminoglycosides. Polycationic structures of aminoglycosides requires parenteral administration. Oral administration is ineffective. Hydrophilicity causes relatively low volume of distribution, but the drug can still pass the placental barrier. This would endanger an unborn fetus. The primary elimination route of aminoglycosides is through urination, and 90% of the drug that is administered will pass through unchanged. Concentration-dependent characteristics of aminoglycosides implements a direct relationship between drug dose and severity of side effects. Geriatric patients are particularly susceptible to adverse effects due to their reduced metabolism. Aminoglycosides can be harmful to the ears due to drug accumulation in the endolymph and perilymph of the inner ear. Drug retention in the proximal tubular cells of the kidneys disrupts the calcium-mediated transport system, resulting in varying severity of renal dysfunction. High doses, or when administered in conjunction with neuromuscular blockers, can cause neuromuscular paralysis. Patients with myasthenia gravis are particularly at risk. Linezolid are specifically used for eliminating resistant strains of gram-positive organisms. They target the 23S ribosomal RNA of the 50S subunit. This inhibits the formation of the 70S initialization complex. Resistance to linezolid is acquired through reduced affinity of the drug to the 50S subunit binding site. Linezolids can be completely absorbed through oral administration, although parenteral routes are also an option. They have a wide volume of distribution and are metabolized by enzymes through oxidation. Once metabolism has occurred, they can be excreted either renally or non-renally. Side effects include gastrointestinal upset such as nausea and diarrhea. Headaches and rashes are also common reactions. When linezolids are used for more than 10 days, thrombocytopenia can occur. The effects of linezolids on monoamine oxidase, and selective serotonin reuptake channels, in conjunction with the consumption of food with high tyramine concentration, may lead to serotonin syndrome.
Macrolides and the ketolides. These are a group of antibiotics with a microcyclic lactone structure to which one or more deoxy sugars are attached. They belong to a polyketide class of natural products, and some of these agents have antibiotic or antifungal activities. The macrolides suppress or inhibit bacterial growth rather than killing the bacteria completely. Ketolides and macrolides have similar antimicrobial coverage. However, ketolides are active against many macrolide-resistant gram-positive strains. We have erythromycin. This was the first of these drugs to find a clinical application both as first-choice drug and alternative to penicillin in individuals with an allergy to beta-lactam antibiotics. We have clarithromycin is a methylated form of erythromycin. We have azithromycin, have some features in common with and others that improve upon erythromycin. We have telithromycin is the first ketolide antimicrobial agent. Macrolides are indicated for the following: Strep's infection, Streptococcus pyogenes, group A beta hemolytic streptococci, mild to moderate upper respiratory infection and lower respiratory infection, Haemophilus influenza spirochetal infections, syphilitic and Lyme disease, gonorrhea, chlamydia, and myoplasma. However, these drugs are contraindicated in people who are having an allergy reaction towards them, and they should be avoided in patients with liver and kidney failure and prolonged QT interval, also in a second trimester pregnancy. So the mechanism of action goes as follows. Macrolide is a protein synthesis inhibitor. Macrolide binds to 5-OS ribosomal subunits, which leads to inhibition of polypeptide chain elongation and protein synthesis inhibition, thus resulting in inhibition of growth and multiplication. Macrolides and ketolides pharmacokinetics. Administration. The erythromycin base is destroyed by the gastric acid, thus either enteric-coated tablets or esterified forms of antibiotics are administered. All are adequately absorbed upon oral administration. Clarithromycin and azithromycin and telithromycin are stable in the stomach acid and are readily absorbed. Erythromycin and azithromycin are also available in intravenous formulations. Then we move on to their distribution. Erythromycin distributes well to all body fluids except cerebral spinal fluid, in short CSF. It is one of few antibiotics that diffuses into prostatic fluids, and it also accumulates in macrophages. Clarithromycin, azithromycin, and erythromycin are widely distributed in the tissues. Azithromycin concentrates in neutrophils, macrophages, and fibroblasts, and serum levels are low. It has the longest half-life and the longest volume of distribution of the four drugs. We move on to their elimination. Erythromycin and erythromycin are extensively metabolized hepatically. They inhibit the oxidation of number of drugs through their interaction with the cytochrome P450 system. Their excretion, erythromycin and azithromycin, are primarily concentrated and extracted in the bile as active drug. Partially reabsorbed occurs through the anterior hepatic circulation. In contrast, clarithromycin and its metabolites are eliminated by the kidney as well as the liver. These are the adverse effects of the macrolides and ketolides agents: nausea and vomiting, diarrhea, ringing or buzzing in the ears, allergy reaction, cholestatic hepatitis. This is usually associated with erythromyces. Macrocyclic antibiotic. Fidaxomicin is a macrocyclic antibiotic with a structure similar to macrolides. However, it has a unique mechanism of action. Its mechanism of action: fidaxomicin acts on a sigma subunit of RNA polymerase, thereby disrupting bacterial transcription, terminating protein synthesis, and resulting in cell death in susceptible organism. While it possesses activity against Staphylococcus and Enterococcus, it is used primarily for bactericidal activity against Clostridium difficile. Following oral administration, fidaxomicin has minimal systemic absorption and primarily remains in the gastrointestinal tract. This is ideal for treatment of C. difficile infection, which occurs in the gut. These characteristics also contribute to a low rate of adverse effects: nausea, vomiting, and abdominal pain. Lincosamide. Clindamycin has a mechanism of action that is the same as that of erythromycin. Clindamycin is used primarily in treatment of infection caused by gram-positive organisms, including MRSA and Streptococcus and anaerobic bacteria. C. difficile is always resistant to clindamycin, and the utility of clindamycin for gram-negative anaerobes is decreasing due to increasing resistance. Clindamycin is available in both intravenous and oral formulations, but use of oral form is limited by gastrointestinal intolerance. It distributes well into all body fluids, including bone, but exhibits poor entrance to cerebrospinal fluid. Clindamycin undergoes extensive oxidative metabolism to inactive product and primarily is excreted into the bile. Low urinary elimination limits its clinical utility for urinary tract infection. Most common adverse effects is skin rash, diarrhea, which may represent a serious pseudomembranous colitis caused by overgrowth of C. difficile. Oral administration of either metronidazole or vancomycin is usually effective in treatment of C. difficile.